Before we move on to the first of our international speakers, I just wanted to make a point of thanking our sponsors for tonight's webinar, and they sponsored the educational seminar series for our centre throughout the whole year, and that's Pfizer and Gilead. So we're very grateful to their support, their commitment to supporting education for clinical and researchers around the world. And so thanks very much to Pfizer and Gilead for their support of this event. Well, it's my great pleasure to introduce Professor Andre Kalil, who's someone who over the last maybe nearly 10 years has emerged to be a really good friend for me. I got to know Andre when he was co-lead of the ATS-IDSA pneumonia guidelines for healthcare associated pneumonia and ventilator associated pneumonia, and I got to learn a lot about him and his wonderful scientific mind, and it was a pleasure to work with him at that stage. Many of you will know his name from the COVID literature, where he has been involved in some of the major trials, particularly with remdesivir over the last 12 months. And he comes from the University of Nebraska Medical Center, where he's the director of transplant infectious diseases. He's become a bit of a media darling in the US. I've noticed there's a lot of websites which seek out his comments on latest advances to see what it all means, and that's exactly what I've done here. In the context of antiviral therapies, I'm very interested to hear the opinion of someone such as himself and what he thinks is the state of play at the moment for treating COVID-19 patients. So Andre, welcome. It's 2:45 a.m. Where you are. I hope you've been able to find enough coffee, and we very much look forward to your presentation. Thank you.
Thanks so much, Jason. It is really a true pleasure to see you after all this time. I mean, I think in COVID time, it seems that I've seen you a century ago. I mean, it's quite insane how the time is passing. And I'm seeing Bala too. I've seen Bala in Brussels just very recently, and good to see you, Bala. It's great. I mean, it's sounds like I'm I can give you a hug, I can shake your hands. It's weird. It's how far we are, but how close we are. So. Even though you asked me to record, I could not avoid to be here live, in a live situation, being able to see you and hear you. So it is really a true pleasure, because I think that we have to take the opportunity to really see each other, to see how we are doing, because it matters. Otherwise we become so far from each other. It gets really hard to get this going. So thanks so much, Jason, for the invitation. I don't want to delay here. So let me see if I can share my slides. Let's see, share screen. So let me make sure that. Can you see the slides?
Yep, perfect. Thank you.
Perfect. So I'll be quickly going through just a general list of antivirals, but I will spend most of my time talking about remdesivir, simply because it is the only drug that really has shown efficacy in randomized clinical trials. But I will just kind of show a little bit of the previous process here. So let's just go ahead. I don't have any financial conflict of interest with any of these drugs. I've been funded by the NIH, and the NIH has been pretty much the sponsor for all the ACT trials that I've participated since last year. And actually, interesting enough, it has been exactly 1 year and 1 day since I did enroll the very first patient on the very first ACT trial, February 21st, 2020. I was reminded by a friend of mine yesterday, because it's quite unbelievable that just 1 year and we've done 4 trials, over 4,000 patients in the meantime. This slide is just to show you the complexity of running trials, and I appreciate very much Steve's presentation as well. It was great to see how complex has been the development of clinical trials in Australia as well. In any other country, no different. I mean, we all struggle When we started trial here in February, it was really fast, and in part is because the federal funding, it was released quite fast as well, in order to get the ACT trial running. So in some ways, we had a connection with the Ebola outbreak in 2014-15. We built the very first clinical trial connection for emergent infectious disease, and that, interesting enough, that really was a huge success in terms of starting ACT based on what we learned from the Ebola outbreak as well. So it's a long story that we can probably talk another day, but I decided to write a quick piece in February about the importance of doing high quality science in the middle of a pandemic. And while we can see that, it was well viewed, through the Times through last year, I cannot tell you that I got a lot of angry emails after the publication of this piece in March, because still a lot of people had questions and issues about doing randomized placebo-controlled trial, in the middle of a pandemic. But this is really my whole argument for high science. Is right there, and it's still valid to this day, because it matters, especially in a situation like a pandemic. This slide is just to show you a little bit of the general thoughts about the natural course of COVID-19 pneumonia. And I'm showing you because it is didactic. It gives you a little bit of a sense of direction. But if you're on the trench like me, seeing patients every day, it's not really a reality. I mean, it's this, and I think Bala can understand very well what I talk about when we have so many sepsis patients. With also sepsis was believed to have a very linear progress. Everything was falling, in specific steps, and it's not true. I mean, a lot of these non-linear biology, a lot of this natural history gets very mixed from the beginning to the end. So some patients will be in shock early, some people are going to be in shock early late, some patients are going to require intubation early, some patients are going to require intubation late. So it's nice to have a sense of direction, as we all like to have, but it is a very complex and non-linear disease, and we have to be careful about that. And I think the remdesivir story is going to give us a little bit of understanding of why I'm telling you that as well. This is a long list of potential, anti-SARS-CoV-2 drugs that were somewhat used in observation studies, randomized studies, pretty long. But I want to remind you that the vast majority of drugs that were very strong, had a very strong effect in vitro in the past, did not really pan out to be effective in vivo, or especially in human trials. So it's kind of, I make an analogy the same way that, so many drugs fight cancer are highly effective in rats and mice, become first page of newspapers, but turns out that over 99% of them never make to humans, because they just either don't work or they're not safe. So we got to be careful, because it's very easy to find effect in vitro, but the complexity of the human being between a cell plate with a plate with a few cells, and a human being in which you're going to have to get into the blood, to get into the tissue, and fight the immune system, everything else, it's really something quite more complex. And we have to be very careful about getting too excited with in vitro studies and losing the understanding that you really you still need clinical trials for this. So this is just a very long list that we could spend hours and hours talking about this, but I just want to kind of give you a little bit of a sense of this list. And I want to talk about one specific drug, because we already have about something in the range of 7 to 10 trials completed, randomized trials completed, and a multitude of observational studies done with hydroxychloroquine. And it turns out that the trials have shown no benefit or harm. And this is just the very last meta-analysis published in the Clinical Microbiology Infection as well. So clearly, I would say that probably no drug in medical history has had so many negative randomized trials as hydroxychloroquine. It's flabbergasting to see still that people are used in different parts of the world, because there is absolutely no question that this drug does not work, and there is data that may harm many of our patients. So this is again an example of the importance of doing randomized trials to understand what works and what doesn't work and what can harm as well. I'll spend the next few minutes talking about our very first trial, because that really matters in terms of the achievement that was accomplished and the subsequent trials that we've developed. So in April, we finished in 58 days, the very first trial with over 1,000 patients. We started in February 21st and we end in April. And by then we had actually to go ahead and make a media release. It's something that we are so tired of seeing, but we had to make, because when we saw the multitude of benefits from remdesivir in our very first preliminary analysis, we believed that would be unethical to not give the drug to placebo patients on a placebo arm. That was the very first trial in February, March, and April. So we had to really make that statement, because by then the same day that we found this DSMB analysis, we start offering the drug to every patient that was in a placebo arm of the study. And I'll tell you why. You're going to see why in the next few slides. So it was a NIAID trial, an NIH trial, fully sponsored by the federal government. Was adaptive in the sense that we are open to try different drugs. This was not a remdesivir trial. It was not an interferon trial. It was not a baricitinib trial. It was a trial for everything. So we didn't have any links, any commitments with any company, with any drug. It was a very independent committee in which we looked for the therapies that were most likely to have success based on the evidence that we had. And at that time in February, the only drug that looking for animal studies, vitro studies, in vivo studies, and a little bit of experience with the Ebola, with remdesivir, we thought that would be the drug that should be first tested. And as you can see, it was a very traditional approach in terms of providing the placebo, having the double blinding, and having actually also very interesting. We from the beginning, we decided to stratify these patients. Randomization was stratified by site and by disease severity. This is really, really important. That has not been done in any other trial in the last whole year of pandemic. And I think that really matters in the quality of the randomization process. So multi-center, double-blind, placebo. All the patients had to have hypoxia or radiographic infiltrates, supplemental oxygen, mechanical ventilation. We were concerned about the hepatitis, because we knew that there was a potential of remdesivir causing hepatitis, and if patients had already COVID hepatitis, we would not enroll these patients with the safety concerns. The primary outcome was very clinical, very much what we see in the bedside. We want to see the patients out of the hospital. We want to see the patient really doing well and out. So correct. So basically the patients have to be out of the hospital without the need for medical care, without the need for respiratory care. That's unambiguous. It's very clear. We thought that powering for mortality the trial would not be able to really to be completed in a timely fashion, because it would require several thousand patients at that time. And with the whole process of really making the double blind and the placebo control in a number of sites, we believe that we really had to get this going fast and effectively. And time to recover was something that was very meaningful to our patients, very meaningful to our healthcare providers. And that was the primary outcome, but surely we had the 14 and 20-day mortality as our secondary outcomes, very, very important, as you're going to see here. And then this is the classic consort diagram that I'm not going to spend much time. The baseline characteristics were quite similar between patients. That's important because, as you can imagine, sometimes even with the adequate randomization process, you can end up with imbalances. We didn't see any imbalances here. So this is the very, primary outcome graph, the very most important result that we have, that shows the curves clearly separating from the very beginning to the end in terms of having patients without the need for medical care, without the need for oxygen, and out of the hospital. That really matters. That survival curve, that Kaplan-Meier tells a very, very, very interesting story in the sense that there's no questions that in a study, rigorous the way that was done, you can see the benefits of these curves. Basically, that the separation of these two curves means 5 days overall out of, earlier out of the hospital. And if you look in the majority of the patients, including Act 1, that were with the moderate to severe disease, there was a 7-day shorter, time to recovery in patients that receive remdesivir versus placebo. This is in the middle of a pandemic. This is exceptional because there is no antiviral that has ever shown, a week shorter time to recover physically out of the hospital and without the need for medical care. So that was really very important. That was what made us to switch all placebos to receive remdesivir in the trial. In this forest plot that basically shows the subgroups, you can see that if the patients were in North America, Europe, or Asia, or if you look at race and ethnicity, the point estimates are all pretty much favoring remdesivir. So this is important because if you remember well, still there's a lot of questions about ACE2 receptors, ethnicity, gender, age, in terms of susceptibility to more disease severity. And you can see here the estimates by age, by sex, by symptoms, baseline severity. They all pretty much see in the same side. Interesting enough, and was a surprise to me when I look at symptoms, that comes to what we talked about in the very first slide of the natural history of COVID-19. We noticed that even patients that had symptoms for more than 10 days still benefited from remdesivir. So this is definitely very important because the initial concept that if you don't give an antiviral right there in the first very few days, as we had with influenza in the past, likely you would not benefit the patients. But there is no questions when you look into our study that patients that were 2 weeks out of the disease still benefited from remdesivir. And so that tells us what we already learned after Act 1, that a lot of patients that are in the ICU intubated and quite ill, they have a very high replicating virus. So I've personally have seen many patients intubated with a viral load that was quite impressive, and they already are 2 or 3 weeks out from the disease, from the initiation of the disease. So it's really quite incredible, seeing such a high viral load replication so late in the disease. It's something that we've not seen with any other viral disease in the past. And so this table, and I put in blue arrows and red arrows to separate. The blue arrows are the primary and the key secondary outcomes. So primary outcome was the time to recovery. Right in the bottom of the slide, you can see the key secondary outcome was the ordinal score. So that's the WHO ordinal score, how fast you go from a more severe respiratory support to a less severe respiratory support. Let's say from ventilation to high flow, from high flow to nasal cannula, from nasal cannula to no oxygen. So you move from one score to the other basically 50% faster. As you can see, the odds ratio right in the bottom of this table, 1.5, 50% faster from one score to the other if you receive remdesivir again compared to placebo. The red arrows show the mortality, and these 4 red arrows showing the mortality reduction of remdesivir with placebo. I'm going to show you the actual Kaplan-Meier graphs that were not in the very main manuscript, but you can see in the supplement as well. So this is the 28-day Kaplan-Meier of survival of remdesivir versus placebo. You can see that there was a hazard ratio of 0.73 and did not reach the significance with a P of 0.006. But as you can see, most of the 95% CI is on the side of remdesivir. As you can see, the separation of the curves. When you look at 14-day survival, that was the more immediate response to remdesivir. There was a highly significant survival benefit with a 45% reduction in mortality in the first weeks in patients that received remdesivir. When you look into the ordinal score 5, these are the patients that are receiving supplemental oxygen that were, kind of in a moderate to more moderate severe clinical picture at the admission of the trial. there was a highly significant survival benefit with a 70% reduction mortality in these patients at 20 days, and with the same 70% reduction mortality significantly as well at 14 days. So clearly there was a overall significant survival benefit at 14 days, a strong trend at 20 days, and a statistical benefit in both 14, 20 days in patients that were receiving supplemental oxygen. This is an important part of the story that sometimes gets lost in the discussion. This is to me also very complementary to the mortality benefits, because if you see mortality benefits, you really want to see other clinical benefits. So what I mean about that, you want to make sure these patients leave the hospital, or you make sure that these patients require less oxygen, you want to make sure these patients require less mechanical ventilation. And there was a something range of 30 to 40% significant less progression to mechanical ventilation and death in this patient that received remdesivir as well. All these red arrows show statistically significant results in terms of reduction on the need for oxygen and reduction on the need for mechanical ventilation in patients that receive remdesivir. And this is exactly what you want to see with an antiviral medication that provides benefit in patients that are moderately to severe ill. And finally, the safety outcomes, we looked very, very in depth. We had a very, very extensive case report form, considering that is a trial done in the middle of a pandemic for safety, because we believe that safety really could not be shortcutted as has been in some other trials. We are very, very thorough about this. We looked for, basically clinical progression every day, laboratory every day, liver function test, renal function test, the whole thing. And we could not see, at least in this cohort of the entire Act 1, we could not see difference in terms of serious adverse events, discontinuation of drug, or any other safety between remdesivir and placebo, including liver function tests, renal dysfunction. So it was a pleasant, kind of result as well, because we had no idea what would be the safety with a drug that has never been used in humans. Specifically with COVID-19, it was a very small cohort and during the Ebola outbreak, but we didn't have too much of an experience in terms of safety. So the highly significant results and the mortality reduction in the safety profile led us to change all the placebo to remdesivir in the trial. Last, I just want to spend a minute, because there are several other trials that have shown the benefits of remdesivir as well, sponsored by the manufacturer. But there's one trial, Discovery, that did not show benefits with the remdesivir, and the other drugs that were tested was recently published as well. I just want to point out the difficulties that are there in terms of understanding the effects of solidarity. Here's each one of the drugs that were tested in solidarity, as you can see in the original publication. So that slide shows really, the difficulty to interpret this trial. So they didn't have any placebo. There was no double blinding, and this is especially in a situation in which you have like 40 countries enrolling in this trial. It becomes very hard to understand how the treatment assessment was done. So there is a very very high risk for bias when you don't have double blind, when you don't have placebo. There was no true randomization, so there was a lot of limitations in terms of investigators choosing each one of the drugs and for each patient and the availability of these drugs. So there was really a very difficult process of randomization. There was no stratification that especially in a situation where you have hundreds of sites in so many countries, becomes very hard to understand. So if you don't stratify, you can end up with with your first patient in your hospital in your country being highly severely ill, and your second patient being mildly ill, and you're comparing apples with oranges because you don't have the stratification in your randomization process. This is really a problem when you have such a heterogeneous patient population at trial. There was no local data monitoring, so there is no diagnostic verification. All they needed some description that the patient had a positive SARS, because as you know, a lot of other viral disease, a lot of other pneumonias can look like very much COVID-19, and patients can be treated as COVID-19 and they didn't have COVID-19. Timing to symptoms was a problem. There was absolutely no timing, so you could be giving, and I know for a fact from investigators from the trial that there were patients that were having the symptoms for 3-4 weeks, patients that were having symptoms for 3 or 4 days. So if you end up like literally randomizing patients to patients with such a disparity of timing of disease, it's very hard to judge any therapy, because at this point you're catching very different points of the natural history of the disease that are not comparable. Same problem with the usual care, as Bala pointed out in recovery as well. So there's absolutely no collection of what was a supportive care. There's no understanding what usual care means. And actually, we do know that several of these countries that were in the discovery trial were having difficulty getting IV fluids available in their hospitals. Several of these countries were having difficulties getting oxygen tanks and oxygen delivered to their patients. So when you reach a level of such a disparity in the infrastructure, the supportive care changed radically. And what happened is, once the supportive care is so different from one place to the other, mortality is going to be different as well. And it's going to be hard, to not say impossible, to judge any therapy when you have such a heterogeneous supportive care, because we do know for a fact 1 year later that supportive care saves lives, and supportive care really matters for patients with moderate to severe COVID-19. As I always say, if you have somebody in septic shock from Staphylococcus pneumonia, from a hospital, let's say for MRSA pneumonia, you can give, whatever antibiotics, you can give the strongest, the most effective antibiotics. If the patient does not have, a good ICU to be taking care of this patient in terms of ARDS, in terms of respiratory needs, sepsis, severe sepsis, IV fluids, the patient's not going to survive, because you really need the supportive care. COVID-19 has the same issue. If you don't provide adequate supportive care, treatments are not going to be able to be, effective. And a randomized trial then is not going to really be very informative, because even if you do a randomized trial, you're going to end up with patients dying from the lack of supportive care, not because of the, of the utility or not of the therapy. And so solidarity really was a poor quality study design, poor conduct, and high risk of bias that cannot in any way or fashion change what we already knew about remdesivir from Act 1 trial. And that's what led FDA had the solidarity trial available on their evaluation before the approval of remdesivir for the use in the US. And they didn't believe that also changed the approach. And the IDSA and the Society of Critical Care Medicine also are recommending remdesivir as well, even though after knowing the results of discovery trial. So I'm just going to stop here and be open to questions. Thanks so much, Jason. Thanks so much for the invitation.
Thanks, Andre. Wonderful presentation and overview of that area.